This is LiveWell Talk on tobacco cessation. I'm Dr. Dustin Arnold, Chief Medical Officer at UnityPoint Health, St. Luke's Hospital. Each year, more than 480,000 people in the United States die from illnesses directly related to tobacco use. That's 1 in 5 deaths. Tobacco use not only causes cancer, it can damage nearly every organ in the human body. Fortunately, there are various approaches to quitting for good. Here to tell us more about tobacco cessation is Mary Jo Henry, Tobacco Treatment Specialist with UnityPoint Clinic Multi-Specialty. Welcome.
Thank you for having me.
You know, nicotine addiction is such a horrible condition to have. Some people are more addicted, if you will, than others. Some can easily quit, some cannot. I remember my own father having a bilateral below-the-knee amputation for peripheral vascular disease and still wanting to smoke, knowing full well that it was cigarettes that caused that. You know, so if losing your legs is not a motivation to quit, it's hard to imagine what would be. Mm-hmm. And I know you had some experience in this for quite some time. Mm-hmm. It's interesting that I think people underappreciate the addiction potential of nicotine when exposed to it. You know, they think of cocaine and heroin, and those are all commonly thought of as addictive substances that can't be done without in some individuals. But I think caffeine and nicotine are two that we kind of take for granted because they're so common. Mm-hmm. What's your approach to having a patient curtail and hopefully quit smoking?
Well, first of all, I almost always explain the addiction, how it works, because I think that's really helpful for them and when they're trying to quit. And another thing that I want them to understand the addiction is because of treatment, because of the medications we use. A lot of people are really confused when they're wanting to quit smoking, trying to quit nicotine, and I recommend that we use nicotine replacement therapy.
Now, question. I've always found in my practice that there are different types of smokers. Mm-hmm. There's some smokers that's something to do with their hands. Mm-hmm. Truck drivers, for example, might be something to do with their hands as they drive. Other people are truly the nicotine addiction, and you do see that. So do you break down kind of and categorize or put your patients in specific categories or buckets to say that this is how I'm going to approach this one, or is it just across the board approach?
I think smokers and maybe us as clinicians to try to do that, or we feel like, it's not. I think we underestimate the nicotine addiction. Okay. I think, and I still have patients that are coming to me and they're telling me that their doctors or their providers are telling them it is not an addiction, it's a habit. You just quit. And that is not true. It is an addiction. It's a very strong addiction with a habit component to it. Okay. And so you have to we all have nicotine receptors in our brain, and to get through and manage the nicotine addiction, that has to be addressed. And as long as you keep feeding the nicotine addiction, you're never going to be able to break that cycle. So a lot of people, there is that part, the habit part of it, but you can't minimize the nicotine addiction. It is. And I think it's very helpful for people. I think there is the hand, like you said, the hand, mouth thing. That's a part of every addiction, every nicotine addicted person. That's more of it than another, you know. And no, I don't try to break it up. How I break down what approach or I'm going to go try to help this patient is where they are in readiness to quit. Because we all know we love someone, and like your example was perfect of your father. But until he is ready, there isn't anything anybody can do. Maybe if they aren't physically able to go get the cigarettes, that's
correct. Yeah,
one way. Yeah.
There's always an enabler somewhere with most addictions. But
right.
Yeah. Do you have, what was your first step after you've had that conversation, whether or not they're ready to quit or not? Are there patients out there that can just quit cold turkey?
There are, but it's
What percentage?
I don't know a percentage. I'm sorry, Dr. Arnold. But I think that is the exception.
You could have made up something. I would have believed it. Okay.
I'm not very good at thinking.
All right. Then no, that's fine, Mary. That's why we love you, because you're nice and honest. So what was the first step? You first of all, you get them to look at cigarettes and nicotine as an addiction to a substance.
Mm-hmm. And that it should be considered a disease like any other, diabetes or COPD. It's a treatment plan. We get a treatment plan together and then stick to it. It's different because there is behavior modification. We all know that it's hard to get people to change their ways. I have my training. I received my tobacco treatment specialist through Mayo Clinic, and their approach is using motivational interviewing. And I don't claim to be an all-out expert in motivational interviewing. Basically what it comes down to is helping the patient find their reasons and their motivation for wanting to quit. And if they're not there yet, giving them some things to think about. So when they are ready, they have a little bit of head start. They have some tools in their toolbox to get started.
What percentage of the patients that you work with are already motivated? They're like, I'm here today because I want to quit smoking. What percentage are like, my wife made me come or my doctor made me come?
Well, we're trying to do a better job of screening out those. Not that it's not, that it can't be beneficial. Like I said, I try to plant some thoughts in their mind and give them something to think about if they're not ready. So that's gotten better. And I would say probably, it's a rough guess, but 75% are ready.
Are ready, motivated.
Mm-hmm.
What is the most, I'm sure all motivation's individualized, and I admit that freely, but is it the financial costs, the health risks, the lack of socialization?
Those are all big, very big factors, and very common in a lot of people. Health and the cost. I mean, even if people aren't having health consequences yet or noticeable health consequences, if you figure out if a pack-a-day smoker at a little over $6 a pack for an average cigarette, we're talking about $2,500 a year.
Yeah, there's a guy in front of me at the convenience store the other day, and he bought a pack of cigarettes, and it was like $7 something, and
right.
I was like, oh my God. My dad used to give me a $10 bill, and he'd call up to the handy mart, and I'd ride my bike up there, and I'd buy a carton of Old Gold filters, and it was like $9 and change, and then what was left over, I got to buy candy with, and then I'd ride it back home to him. And then I was just thinking this guy just throws down, a $10 bill and gets, just a small amount of money back for one pack. Right.
And as with any addiction, when you're actively addicted, you're minimizing that. I mean, it doesn't matter how much it's going to cost. You need to have that. You want to have that. And people who can afford that financially, they put it out of their mind. I mean, they just don't think about it, or they try not to. And so bringing that to the forefront and start saying, what would you do with that money? So to help them get motivated, I bring that to light and help them figure out how much they're actually spending in cigarettes. And then when they're, and what would you use that money for? What would you start thinking about that? And then when they're actually cutting down or quitting or have quit, putting that money away, putting it in a jar, putting it separately in a separate account, and really see how quickly that's adding up.
Yeah.
And to use when they meet maybe their first milestone or their second milestone, so they haven't smoked for a month, take some of that money and reward yourself for the hard work. It's hard work to quit smoking. It's much easier to keep smoking. And so take that, reward yourself, and our pocketbooks are a pretty good motivator for us.
Yeah, absolutely. Yeah, and it's interesting how things have changed. It used to be that the non-smoking section of a restaurant was a card table in the back of the storage room, and the nice section was the smoking section, and that certainly has changed. I had a patient one time. She was in the Navy, and other sailors would go up deck to have a smoke break, and then she went up once, and she wasn't a smoker, and she was reprimanded. You can't just come up here, but it was okay to go up and smoke. So she started smoking so she could get these breaks, and then help work with her with when Wellbutrin came out for that way back when to get off that. But one of the things I used to do, and I do not have near the experience that you have in assisting people with quitting cigarettes, I would give them the talk, but it's a drug.
Mm-hmm.
And I would say, okay, how many cigarettes a day do you smoke? I smoke 20. I'd say, okay, we're going to go down one cigarette every 3 days until we're done.
Mm-hmm.
And I used to tell them that if it's 10 p.m. at night and you were supposed to smoke 7 cigarettes that day and you would only smoke 5, I said, you got to sit on the edge of bed and smoke those 2 back to back. You have to think of it more as a chemical that you're getting out of your system, and you have to titrate off. And that was really successful for some people. Some people didn't work at all.
Right. And that's why each quit plan is individualized.
Yeah, it has to be.
Absolutely has to be. Nicotine, the receptors in the brain get used to how much nicotine they're given. Okay. And so if you decrease that slowly, it can be a little bit less painful, less nicotine withdrawal symptoms. Okay. And some people, they set a quit date and they want to quit, and that's when they want to do, and that works for them. There's other people, and I find that most of them, especially long-term smokers, prefer the reduce to quit method.
Titrate off, curtail back over time.
Mm-hmm. Mm-hmm. And using any of the medicines almost double their chance of being successful.
You mentioned nicotine addiction, nicotine withdrawal symptoms. Can you tell me what some of those are?
Irritability, difficulty concentrating, nervousness. Less common or less known ones are constipation, because nicotine is a stimulant. Huh. There's all kinds of...
And how long do they last? So
one of the techniques that I use a lot and recommend with my patients is I ask them, do they realize that urge to smoke is going to go away whether they have a cigarette or not? And some of them do, but some of them that is a thought that they had never thought of before. And so I say, that comes to your mind, say, okay, I would like a cigarette, but I'm not going to act on it for at least 10 minutes. And then get busy, do something that distracts your mind from thinking about that cigarette, and that thought and it works. The thought will come back. Okay, if you can delay it again, another 10 minutes, do that. But the thought comes back. Okay, now I'll have a cigarette. So I think it's minutes that the feeling is there and that urge to smoke, but it will go away. It will go away in a matter of minutes. It'll come back. And the more you don't act on it, the longer it is before that thought comes back again. And another helpful technique for the hand-mouth thing is having people talk to them about simulating those motions of smoking without actually smoking. So using an object that kind of looks or feels like a cigarette, a straw. A cut straw is something that...
Well, we can't have those because of sea turtles, though, so that's going to...
Oh, yeah, that's true, yeah. Well, paper ones.
Okay,
I guess we can have paper ones now, right. Yeah. And so when they've delayed as long as they can, and now they're going to have a cigarette, and when they're reaching, instead of reaching for the cigarette, you reach for the straw, and you put it to your mouth like you do when you're smoking. Simulate that inhalation. Hold it, and then a long, deep breath out. And that's very similar to the inhaling of the cigarette. So they get that feeling of the lungs filling up, and but with air rather than the harmful smoke from the cigarette. And then that deep breathing, that purposeful slowing down the breathing and taking the deep breath also helps with the nicotine withdrawal symptoms by calming them down.
The gum and the patch, how do those fit into your treatment?
It's probably what I use the most,
which is the gum or the patch, or
together. My recommendation, unless there's a compelling reason why you can't use one or the other, is to use a combination of long and short acting nicotine replacement. So the patch takes the edge off of the nicotine withdrawal symptoms. And so, but there's still the habit part. And so using the gum or the lozenges when they're having that urge, helping them delay and start to figure out, what am I going to do instead of smoking? What am I going to do to replace this, the time and activity of smoking? And so the patch takes the edge off, and then the short acting nicotine replacement gives them that, pulse of nicotine to help them through the really strong urges so that they can focus their energy on behavior changing and reducing their triggers.
So a stick of gum, nicotine gum, is equal to how many cigarettes?
The ones that I know anyway, there may be sticks, but it's not sticks. It's little squares and maybe little tabs. And they come in 2 and 4 milligrams.
2 and 4.
And if you're using them without the nicotine patch, then you use the 4 milligram. If you're using it in conjunction with the nicotine patch, 2 milligram. But my experience is that they're very similar in cost. And so I just have people buy the 4 milligrams and break them in half.
Okay, well, that makes sense.
Mm-hmm.
So if the patches are 21, 14, and 7, correct?
And that's based on how much you smoke.
So what is that? What's 21 is equal to how many packs a day?
1 pack a day.
1 pack a day, okay.
And I don't know that, I wouldn't say, I don't know that it's equal to, but that is, maybe it is, but I hadn't thought about it in that way, but that if someone is smoking a pack a day, if we use a 21 milligram patch, we should be able to satisfy or calm those nicotine receptors, okay? And a lot of times people will tell me, well, I've tried that and it didn't work for me. Well, how much do you smoke? 2 packs a day. Well, what patch did you wear? Oh, well, sometimes it's even 14 milligram or it's 21 milligram, but it's not enough. Even the 21 milligram isn't enough. And most prescribers, not that you need a prescription, you don't need a prescription for nicotine replacement. It's over the counter. But people, healthcare providers or people who patients turn to help them quit smoking aren't comfortable saying you need to be wearing 2 patches. If they're smoking between 30 and 40 cigarettes a day, it's 35 milligrams or even up to 20 or 48 milligrams.
So 2 patches.
2 patches.
And you just put on 2 24s and to make 48.
Right.
All right. That's a good
right.
clinical parole there.
Mm-hmm.
The pills, the various formulations of Wellbutrin have been marketed for nicotine. Tell us about that. How does that fit into your practice?
I use it. I use it quite a bit. And as I can tell you with the nicotine replacement and also varenicline, Chantix, I can tell you the exact mechanism how those work. We don't know exactly how Wellbutrin or bupropion does help. We think it has to do with that dopamine response that you get from smoking the cigarette, that when you inhale a cigarette, smoking a cigarette is the most efficient way to get the nicotine to your brain. It happens in less than a minute, usually about 30 seconds, that nicotine is at the receptor and that dopamine is being released, okay? So we think that bupropion works somewhere in that pathway with the dopamine. What we do know for sure is that studies show that people who are trying to quit cold turkey, not using any medicines versus using the bupropion, the Wellbutrin, they had a higher success rate.
So it truly is a tapestry woven together for each patient.
Absolutely.
It's so unique.
Absolutely. And in the real world, cost is an issue, and
more so than ever. It's just in general in healthcare, more so than
ever. The studies have shown, so varenicline or Chantix is the first medication that was ever developed to help people quit smoking. That came out in the 90s, and our research shows that it is the most effective. It has the highest success rate. But it's also the most expensive, and it also has the potential for most side effects, okay? But not the research also shows that using the combination of the long and short-acting nicotine replacement almost reaches that of the varenicline.
Well,
and there's less side effects.
The benefit of not smoking is worth trying these different mechanisms. Absolutely. And keep trying. I don't think you're never.
The varenicline, I just like to say how that works. It gets in, it sits on the nicotine receptor in the brain so that the nicotine cannot get there. And so they're not getting the positive or the dopamine response each time that they smoke a cigarette. So there's not that chemical reinforcement to keep doing that.
That gives them some pleasure from it.
They get less pleasure from it.
Prevents them from dopamine release. That makes sense.
And a lot of times they will tell me that the cigarettes don't taste as good when they're taking the Chantix.
Yeah, I like old-time radio shows. They like to listen to them. And, sometimes they'll have the commercials on there. They'll say, 9 out of 10 doctors recommend this cigarette for your asthma. And I always used to, when I was in high school and play fast pitch softball, you'd see these older guys that smoke. They'd run to first base. They'd start hacking and coughing in the dugout. They'd take a drag off a cigarette and their cough would go away. And I used to think that was so weird. And then when I was in medical school and you learn that, there's scopolamine and atropine in cigarettes, tobacco, as part of that causes their bronchial tubes to get bigger, then it totally makes sense that, that short-term relief that people get with their smoker's cough in the morning with a drag of a cigarette, it is the benefit. So, fortunately, doctors aren't recommending cigarettes anymore, which is all for the better. Why? One last question. How did you get involved with the nicotine aspect of multi-specialty practice? I know this has been your efforts have complemented the pulmonology's group's mission for a long time. But how did you end up with? Did you miss a meeting? That's what happens to me. I miss a meeting and then I get a new assignment.
Nope.
So that didn't happen?
No, that did not happen. It was a conscious decision. Like I said, my career started in my nursing career started with the pulmonary patient, and a big component of that was COPD and smokers. And there and still is a lot of judgment, and they feel, especially nowadays. I mean, people know that smoking isn't good for you. There's a lot of guilt involved with it, and that hampers their ability to. They get so caught up in that they can't focus their time and energy on trying to quit, they feel like it's hopeless. I tried it and I couldn't. I can't do it. So that's it. And I was a smoker. I know firsthand how hard it is. And I knew I shouldn't be smoking. I knew all of the bad effects. I, was obviously a closet smoker and hid it, and I felt terrible about it. And so I just felt it's a passion for me. I am so happy that I am not a smoker anymore, and I want to help other people.
Well, that's awesome, Mary Jo. Really great information. Thank you so much for taking the time out of your busy pulmonary practice to visit about this important subject. Again, that was Mary Jo Henry, tobacco specialist, tobacco treatment specialist with Union Point Clinic Multi-Specialty. For more information, visit unionpoint.org. If you have a topic you'd like to suggest for our Live Well Talk On podcast, shoot us an email at stlukecr@unionpoint.org, and we encourage you to tell your family, friends, neighbors about our podcast. Until next time, be well.